Welcome and thank you for joining us. The following presentation is all about bipolar depression, an investigation into 3 different treatment drugs and how they affect the condition. Bipolar depression is what is known as the depression experience in those who have bipolar disorder. Depression is experienced as well as manic or hypomanic episodes. The depression that people with bipolar disorder experience is generally of a melancholic or psychotic type, and therefore more biological in its nature. So how does it all work and what's happening in our brains? Mechanisms believed to be involved in the pathophysiology of depression involve the hypothalamic, pituitary and adrenal axis. These are activated by stress and in turn enhances the excitotoxic action of glutamate, mediated by NMDA receptors, and switches on the expression of genes that promote neural apoptosis in the hippocampus and prefrontal cortex. The pathways involve the monoamines, noradrenaline and serotonin, and the brain-derived neurotrophic factor, BDNF, switching on genes that protect neurons against apoptosis and also promote neurogenesis. The final step leads to expression of depressive symptoms. So let's now look at our 3 drugs and how they can help us. Quetiapine is an antagonist at both serotonin, 5-HT2 and dopamine D2 receptors, and its antipsychotic effects are thought to stem from interactions at these receptors. The antidepressant effects of quetiapine are poorly understood, but may be related to antagonism of 5-HT2A receptors in cortical regions, partial antagonism of 5-HT1A in the prefrontal cortex in association with increased extracellular dopamine release in the region, or to reduce synaptic reuptake of noradrenaline resulting from inhibition of the noradrenaline reuptake transporter by the quetiapine metabolite norquetiapine. The common adverse effects of this drug are extrapyramidal side effects: sedation, somnolence, dizziness, fatigue, constipation, dry mouth, increased appetite and weight gain. This medication may also make your blood sugar level increase, which can cause or worsen diabetes. Lurasidone is a serotonin and dopamine antagonist and also potentially a mood stabilizer. Lurasidone blocks serotonin and dopamine receptors in the dendrite, which are both in the mesolimbic circuit. This blockage reduces positive symptoms because when the mesolimbic pathway is overactivated, the positive symptoms surface. By blocking the receptors, less signals from the neurotransmitters will be propagated along the pathway. Latuda reduces positive symptoms but cannot eliminate them. The side effects of lurasidone are weight gain, dizziness, nausea, somnolence and shaking. This medication may also cause a serious drop in blood pressure. Infrequently, it can also cause face and muscle twitching and uncontrollable movements such as lip smacking, mouth puckering, or unusual arm and leg movements. The mechanism of action of olanzapine and fluoxetine combination is unknown. It has been suggested that activation of 3 monoaminergic neural systems, norepinephrine, serotonin and dopamine, is responsible for its enhanced antidepressant impact. In animal studies, olanzapine and fluoxetine in combination has shown to produce synergistic increase in norepinephrine and dopamine release in the prefrontal cortex and also increase in serotonin. This short sequence depicts fast dissociation from D2 receptors. Second-generation antipsychotics are loosely bound to the receptor. In the presence of D2, the drug easily dissociates from the receptor and D2 moves in. The main side effects of concern for olanzapine-fluoxetine treatment are increased appetite, which leads to weight gain. The significant weight gain can cause an increase in your blood cholesterol levels, particularly in teenagers. This medication may frequently make your blood sugar levels so high, an impact that may cause diabetes. The other side effects to this drug are dizziness, drowsiness, diarrhea, dry mouth, constipation, and problems in sleeping may occur. These impacts, along with diabetes, may increase your risk for developing heart disease. We can now see the advantages and disadvantages of one drug over the other. Lurasidone is 15 times more expensive than quetiapine and 30 times more expensive than olanzapine, making it accessible only to patients who can afford it. It must be taken with food, as does quetiapine, and lirasidone cannot be taken alongside other drugs of treatment, whereas quetiapine and olanzapine fluoxetine treatment can be given in combination therapy. Lirasidone is not habit-forming and does not require dose titration, unlike the other two drugs. It has low weight gain and diabetes risk, which is moderate for quetiapine and high for olanzapine fluoxetine. Olanzapine results in minimal extrapyramidal symptoms, unlike lirasidone, but can cause a decrease in sleep quality. So you ask, which is the better drug? It all depends on the individual, their medical history, and what they are predisposed to. This will determine which of these treatments are best.